I am now going to introduce our fourth speaker, Professor Anne John, who is joining us via Zoom. And Anne holds a personal chair in public health and psychiatry at Swansea University Medical School, and she's a clinical epidemiologist with a background in public health and general practice. And her research focuses on suicide and self-harm prevention and children and young people's mental health. And she is the PI and co-director of DATAMIND, which is the MRC-funded HD UK mental health data hub. So we're delighted to welcome her this morning, and we very much look forward to hearing her talk. So thank you.
Thanks very much. I'll share my screen. Is that all there? I'm assuming it is. So I basically came to epidemiology and data through quite a convoluted route. So I started off as a GP, then I felt that a lot of the work that I was doing was basically sticking plasters on where the causes had already happened, and that's what attracted me to public health. And it's when I did my public health training that I got my epidemiology training. Prior to COVID, no one, I think, really knew what an epidemiologist was, but now everyone knows. And my area of interest, so from the beginning of my career, so even in medical school, I've always had a real interest in mental health. And I think some of that stems from the fact that I think things have changed, but there was so much stigma associated with mental health that people who experience mental health problems were often quite excluded, both from society but also research. So if you think about funding for research, if you compare mental health funding to research funding for cancer or cardiovascular disease, there is no comparison. And that has changed slightly over the last 5 years, but there's a lot of challenges, I think, in this area that are very particular to mental health. So I'm going to talk about DataMind. DataMind is I'm just having trouble forwarding the slide. So DataMind is a health data research hub for mental health, and it sits within HDUK. It is funded by the MRC, and there are 9 hubs covering other disease domain areas. And so you've heard from disease, but there's also gut reaction, and as well as respiratory, there's cardiovascular disease. We were DataMind and Alleviate, which is the hub for pain, were funded in the second round. And they stem from the fact that both electronic health records, but also other data, there's a history, I think, of a division between research going on in services and research going on in universities. And as clinical academics, we try and sort of bridge that gap. But then also, there's issues around the thing about real-world data as it speaks to people. But everyone is using slightly different definitions. Up until now, there's been very little consistency in the way that data is used across the NHS. So very naively, we did a project during COVID where we looked at hospital admission data across the 4 nations. And very naively, I thought that would be stacked in the same way across the NHS. It isn't. So these hubs are all about making that data accessible and discoverable across the NHS, academia and industry. while working alongside the public to make sure that they feel that it's happening in an appropriate way and that we cover appropriate topics. So HDR UK is sort of the Institute for Data in the UK, and they both hold sort of the hubs sit between what's called the UK Health Data Research Alliance, which is the leaders across NHS, cohort studies, registry data, and trials data will sit in there. But also there's an innovation gateway that's very much worth you having a quick look at, where we, so one thing that happened to me recently was I got called in very late to one of our health board meetings, where someone had been employed for about 4 months to develop a code list, a read code list. So those are the codes that we use in primary care to find cases of people who would self-harm. Now, I work really strongly. I work a lot with the NHS and policymakers, but they didn't know to come to me. And so someone had spent 4 months developing code lists that I could have handed them off the shelf. So it's really important that we, that all these sorts of research-ready innovations, algorithms, code lists, how we analyse data, is really accessible to people across all those domains, and that's what the hubs are doing. So within DATAMIND, we had a number of objectives. Now, mental health data is considered somewhat more sensitive than other types of routinely collected data. Now, we've done lots of work to look into whether that's true or not, and it is true, but maybe not as strongly held as people might think. And I guess it's not surprising either, because when we take a mental health history, we're asking questions that you don't ask in an ordinary history, that are much more personal. So people feel that their data is more personal. So we have a very strong super research advisory group that are both advising us on the things that we do, embedded in all our governance structures, so the leadership groups, the whole team meetings, all the projects. But they're also working with industry to develop a set of global standards where we can work out the limits around the relationship in the way that industry can access data. We work with the Gateway and HDR UK to make data sets visible, accessible and available for research. Now, we all know there's lots of studies out there. There are the big ones, big cohort studies, like the Millennium Cohort Study that we might know about. When I was in the NHS, purely in the NHS, I didn't even know about things like that. But equally, there are studies that researchers do, and then the data sits on their server, and you don't know it's there, and you don't know how well it will answer your questions. So we are mapping those data sets, and along with metadata, making them available that are particularly focused, so cohorts of people with severe mental illness. We're developing those global standards. We're working to develop capacity. So having people who both understand mental health, but also good data scientists. It's very hard to find one person that has all those skills. And there's a real capacity issue in terms of mental health data science, and probably data science across the board. So we really need to develop multidisciplinary teams. But in order for multidisciplinary teams to work really well across the NHS, data and computer science, disease domain expertise, people need, and the public and industry, people need to have some level of common language to understand each other. So one of the other things that we've got extra funding to do is to develop a data literacy course. So DataMind is a collaboration across 11 universities, and we add more all the time, but the original universities, that were built on the existing funding and investments from the NRC. So the mental health data arena was slightly ahead of others. The NRC had funded, just counting the numbers, 8 Pathfinder projects. I led the one in Swansea. So when we were developing DataMind, we brought all those universities together, but also included Manchester and Queen's University Belfast, so that we had a 4-nation approach, which gives you the benefit of scale and reach. We partnered, as well as partnering with universities, we partnered with MQ, which is the only charity there for mental health research that develops some sorts of funding pools. And we partnered with MQ to work with us, particularly on developing capacity and training. We also included the CSOs from the 4 nations, the core COVID national centres were included, other hubs, and what we call federated trusted research environments. So as you know, to keep data safe and secure, we work in trusted research environments. Now sometimes there are moves to have one great big trusted research environment where you can securely access the data. But we very much federated approach because we think it's going to be very difficult to get Scotland, England, Wales and Northern Ireland, as well as certain trusts, certain health boards, to all put their data in one place. So we need to find solutions to do equivalent analyses at scale across those different environments. So this is our team. We have the leadership team, which is predominantly researchers, academics, and then the management team. So as you all know, to try and keep that sort of network together, you've got to have people ensuring that all the different component parts are meeting their targets. So we had 4 core activities, so that's public and participation work, the fair, findable, accessible, interoperable and reusable, so those are the objectives and principles I've just talked about, data. Business development and sustainability. It's about making sure, so DataMind is funded for 3 years, it's making sure the work will carry on, and then that training capacity piece of work. We focused on 4 challenge areas, which are important in mental health. So children and young people, we know that self-harm, anxiety, depression and suicide are increasing in that group. Pre-COVID, excluded and underserved groups, these were the groups that were particularly highlighted during COVID with huge experiences of health disparities. The interface between physical and mental health. And that's where both I think in academia and the NHS things have improved, but we still often work in silos. And outcomes from physical health treatments are absolutely impacted by people's mental health issues, be they prior to the physical health issue or post it. And similar with mental health, it's a bi-directional relationship. And severe mental illness, which is a challenge area because those with schizophrenia or bipolar disorder on average die between at least 20 years before everyone else. We also funded some very focused projects based in schools using natural language processing. So, when you work with what in the health service we put down as a diagnosis code or a referral code, For mental health, a lot of the real meat of what we understand, a lot of the way we can stratify people to do precision treatments and medicines within the free text data. And the only way to access that is through natural language processing. We've got one on digitally enhanced trials that really focuses on the fact that, within trials, they're very rarely representative, and we're developing tools to what we're calling equity tools, so that trials can report very clearly on, how many people have a mental health diagnosis, how many people from ethnic minorities are in the trial, so that we can work towards improving representativeness of the results of trials. So one of the things we focused on, so this is all infrastructure stuff. I will come on to some of the work that we've done in this area. So we have a thing called the Catalogue of Mental Health Measures, which we're integrating with the Data Gateway. I would really recommend going and having a look at that, because the metadata from so many studies is there if you're looking to do mental health research, and it's easily searchable. In DATAMIND, we're adding links to physical health data, genetic summary tables. We're trying to find ways that people use the same measures. So, we did a project on cyberbullying, and we went and looked at all the data. And most studies asked very different questions about cyberbullying. So in some studies it was, have you ever been hurt by something someone said online? Ever. Others, well, has it happened more than 20 times in a month? So when you are trying to compare those studies, it's impossible, because they're not talking about the same things or experiences. So that level of data harmonisation, which can fundamentally happen at, when people are talking about depression, are they talking about the same thing? That's part of making the data work, and data from the third sector. And we're developing those sorts of code lists and putting them on the phenotype library, so that if you were doing a project based on routinely collected data, so the sort of data that we generate in health services, or education services, or social care, you can go to this library and pick a phenotype, which is the code list for something like, say, depression, and be measuring the same thing as everyone else. And then we have a big piece of work about working with the public and patients. We've seen all sorts of issues around sharing of data, whether that is, aggregated data, so data where you can't pick apart anyone. It would be 57% of people have this. Anonymised individual data, but where people are consented. So that comes from usually very specific research projects. De-identified routine patient-level data. Well, that's the sort of data that I work with, where it's fusion-anonymized. Or identifiable NHS data. And the legal and governance requirements for each of those differ. And what we're planning to develop is sort of a way that those governance structures align with what people understand and expect. But also there are barriers to doing research that everything points towards people are largely supportive, particularly the NHS and academia, accessing data to do research for greater good. And we don't want to put barriers to that. So with the work that I do, I particularly work with data linkage. So that's where we say link across primary care data and secondary care data. Now, why bother doing that? Well, you can have, well-designed studies that collect data but to answer particular research questions. And the reason that's important is people with poor mental health may be the least likely to take part in studies where they have to answer lots of questions, or where people come into a school and they have to answer a survey. Often kids with anxiety will not come into school. Many of the measures are self-reported, so people get asked, have you got a mental health measure? So they're subject to bias, because there are mental health problems that are part of everyday life, and there are diagnosable mental health problems that have different outcomes. So clinical meanings can be unclear. And also when you look to studies, people with particularly severe mental health problems are also people with suicidal thoughts and behaviours. They're often lost to follow-up. So although they really participate in that initial piece of the research, we never know what happens to them in the future. And these problems are partly overcome by using routinely collected data. If you can send people to link, to have their data linked, you can follow them up for a long time. And data linkage is real-world data. So what I find is it really speaks to policymakers, the public, and practitioners. It's not seen as something tested in the very rarefied world of the trial. So in Swansea, we are international leaders in this sort of data. And we work in a trusted research environment with linked data for the whole population of Wales, anonymously linked, privacy protected data in the SAIL data. So what sort of work can we do? So we looked at prescribing in primary care for antidepressants to children and young people. And what we found was, that prescribing had increased. It had particularly increased for older adolescents. But we also found that diagnosis of depression had reduced. Now that goes against everything that we hear from survey studies. And what we think had happened was that GPs were strategically labelled. So because of QOF, we had to follow people up. And so sometimes GPs were using symptom codes that they were treating rather than diagnostic codes. So understanding what's happening in the data is really important. But we also found, so NICE guidance was such that first-line treatment is always psychological therapies. But psychological therapies are difficult to access. There's long waiting times. For young people with depression, waiting with no management carries risks. People might develop suicidal thoughts. So often GPs were managing that gap in provision with prescribing. But what NICE recommends, and what all the safety results show, is that the first line of antidepressant treatment should be fluoxetine in under 18 months. But what we saw was more prescribing with citalopram, and which doesn't have a similar safety profile. So as a result of this work, advice was issued to all the GPs in Wales about prescribing. Case studies were developed. I appeared on John Craven's news round, which is literally the only time in my life that my children show no interest in what I do. So it's really, really, this sort of work, this sort of linkage work, both speaks to the mechanisms of problems, understanding why people develop things, who develops things, but also works towards service improvement, because at scale you can look at what sort of treatments are happening, who's getting referred, who isn't. And that brings me to this study. So we also did another study where we linked hospital admissions, outpatients, emergency department, and GP attendance in children for self-harm. And we did find that contacts were increasing. We found that, females were much more likely to present to primary care. Older adolescent males much more to emergency departments. But very interestingly, we found is, not dependent on method used, that females were much more likely to be admitted to hospital than boys. And really, everyone under 16 who presents to an emergency department with self-harm should be admitted for assessment. Now, we thought, maybe that's because girls self-poison more, and so they need, their drug levels down. It was irrespective of method. And one of the things we thought from this study was that, we talk a lot about men and boys should seek help more for their mental health problems, but we don't reflect on how we respond, because we are all part of society, to males in distress. And what this study showed you is it gave you a hint that maybe we respond to males in distress differently to the way we respond to females in distress. And as a result of this study, we were contacted by a lot of schools saying that, that increase that we saw was very much in keeping with things that they were experiencing. And that had two consequences. So one, we developed guidance on how to respond to issues of self-harm and thoughts of suicide that was sent to every school in Wales by Welsh Government, not by us. And then we did right. And two, we decided to look at self-harm in schools. And we did a number of studies, but the one that I found most interesting was we linked school absence and exclusion data, so school attendance data, to diagnoses with ASD and ADHD, a range of mental health problems from anxiety, depression to more severe disorders, eating disorders, not severe, but severe disorders as in schizophrenia and bipolar disorder and eating disorders and self-harm. And we know that poor attendance has a real impact on future trajectories. It has an impact on achievement, it has an impact on job opportunities, it has an impact on mental health, problem solving. So we looked at over 400,000 children across 4 school years. We took their diagnoses up to the age of 24 because it takes a long time to diagnose mental health problems, and some don't get diagnosed in the early 20s. That's schizophrenia and bipolar disorder. But their manifestations can be seen when people are of school age. Now, I'm showing you the results for self-harm here. What we found was, irrespective of what the diagnosis was or the behaviour, there was a big increase in absence or exclusion across all disorders. It didn't matter what the disorder was, really. So here, the black line is where there's no self-harm, and the orange line is young people who self-harm. So pupils with a record of self-harm were twice as likely to be absent. If they came from a deprived community, they were much more likely to be absent in general. And if they had special educational needs status, that reduced the likelihood of them being absent. So there are things we can do that help. The situation was even more stark when you looked at exclusions for self-harm. The rates were 7 times higher in levels of exclusion in young people who self-harm. And boys with a record of self-harm were 2 times as likely to be excluded. And again, having special educational needs status reduced the likelihood. So children who self-harm but have any mental health diagnosis spend less time at school. we looked both ways, so we can't talk about causation. But I guess what I would say is, what I often say to the data scientists on my team is we're not doing rocket science. None of you are surprised, I'm sure, that people who aren't in school have high levels of mental health problems. However, what our focus is 100% attendance certificates being punitive when young people aren't in school to them and their families. Whereas what we're doing is showing that actually we can use that attendance data to highlight children who are in need of extra support. And that data is collected routinely. You know, we're not asking schools to do anything extra in terms of identifying these children. So what routinely collected data can do is really show you where you can target, where there are disparities and where you can make a difference. Now, during COVID, I can see I'm running out of time. We demonstrated those same dips in contacts. So this is contacts with self-harm. So the dashed line is the 3 years previous to COVID, and the red line is sort of up to March 2021. We know the reasons why people didn't go: fear of infection, stay-at-home orders. But what we were hearing on the ground was that self-harm attendance had increased. It hadn't. But the proportion, so it had, which is why we think people have that impression it had increased. So with the drops you saw in attendance of everything else, attendance for self-harm didn't drop so much. So the proportion of everyone going to A&E was bigger than it was pre-COVID. And that's why that impression was there. And that's why it's really important to analyse this data at scale. Because when we're working clinically, we have a very detailed picture of what's in front of us. But we sometimes don't see the context of that. So that's why it's really important to do this sort of work. I'm going to rush a bit more. And then with suicide, we were all very concerned about an increase in suicide rates during COVID. And a bunch of us got together and wrote an editorial, the diagram of which is in the bottom corner, where we highlighted all the things we thought would contribute to suicide increasing. And those, lots of figures were put all over the place because the issue was very much conflated with anti-lockdown lobbying. So people were saying that suicide figures are up 200%. Everyone was getting very anxious. But we knew there's a delay in how we count suicide deaths. And we knew that we actually didn't have the data. So I co-led, I'm sorry, I'm not going to be able to go back. So I co-led a global suicide study with Professor Jane Perkis from Melbourne. And what we found was that we collected data from all over the world. Researchers really came together and contributed their data. And what we found was that suicide rates had remained stable or reduced in almost all the countries. We had data from 35 countries. So I guess the data world presents opportunities and challenges. You know, we have lots. In the UK, we are rich in data resources, but we need to think more broadly. We need to make sure that those data resources are interoperable and accessible. We want to harmonise so people are measuring the same things, but we don't want to create extra problems. And there are issues around how we do work nationally and locally. So for those of you who watched this, how do you get involved with DataMind if you're interested? We hold a data science meeting every year. I have really good feedback this year, but we also hold data science workshops to working with mental health data. They're very needs-led, so we asked what people want. We led one, we had a day's programme on programming on the 27th of December. They're open to everyone. So, if you go to our website, so the big website's under development, but I'll make sure you're okay with that. You can find access to these sorts of workshops. So I'm going to stop there.
Thanks very much, Anne, for that really great presentation and all those very practical examples that I think are applicable to us here, particularly those working in child and adolescent mental health.